This is an example of a GATT performed by a PGY4 under my supervision. This resident had performed approximately 200 cataract surgeries prior to this GATT. The steps in this video are not sped up and shown in real time. The resident begins the case by making a 1 mm paracentesis and injecting lidocaine and epinephrine into the AC. A subincisional hook was placed, followed by air, then trypan. The trypan was rinsed out and the AC was filled with Helon 5 Pro. This viscoelastic helps maintain the AC, doesn't burp out of the main wound, and helps tamponade reflux bleeding from Schlemm's canal during the GATT. The resident made the main wound, which purposely starts a little more anteriorly compared to the wound for a phaco alone. I advise the resident that it's important to not nick any blood vessels when making a main wound for angle surgery, because blood that gets between the cornea and the gonioprism will obscure the view to the angle. The resident used a 0.5 mm grease-harbor blade to make an incision for the iTrack catheter. The catheter was primed with Helon Pro, inserted into the anterior chamber, and advanced into the nasal angle. The catheter was plugged into the light box so the tip would blink. The patient's head and microscope were turned to the side and the gonioprism was used to visualize the angle. A 25-gauge MVR blade was inserted in the wound and slowly advanced across the AC until it reached the trabecular meshwork, taking care not to bump into the lens, iris, or cornea. The MVR blade was used to incise the trabecular meshwork to make a goniotomy so the iTrack catheter could be inserted into Schlemm's canal. The resident readjusted the gonioprism when a bubble appeared in the view. The bright white back wall of Schlemm's could be seen by pulling down on the posterior lip of the goniotomy. The resident kept the gonioprism on the eye and maintained an excellent view to the angle while switching out instruments in their dominant hand. The MST forceps were tested outside the eye to make sure that the jaws opened and closed properly. The forceps were inserted in the AC and used to grasp the catheter near the blinking light. The catheter was inserted through the goniotomy into Schlemm's canal and advanced circumferentially. I reminded the resident to not grip the forceps too tightly so as to not kink the catheter. I recommended to the resident to pivot in the wound rather than move side to side, because when moving side to side, the MST forceps can hit the edge of the wound, which moves the eye up and down. I advised the resident not to grab too long of a section of catheter before advancing it into Schlemm's canal because it may buckle. As the resident advanced the catheter for 360 degrees around Schlemm's canal, the blinking red light could be seen going in a circle around the limbus. Meanwhile, I performed 1 click per push to deliver Helon Pro into Schlemm's canal to perform viscodilation. I instructed the resident to let me know if they thought the catheter was encountering an obstruction so I could deliver more viscoelastic. Rarely, if the catheter cannot be advanced for 360 degrees, it can be removed and attempted in the other direction. In this case, the catheter was easily advanced for 360 degrees and the blinking red light reappeared in the goniotomy site. The MST forceps were used to grasp the tip of the catheter and the gonioprism was removed. I pull the catheter from outside the eye while the resident holds the tip of the catheter inside the eye to perform a 360-degree ab interno trabeculotomy. With the GATT complete, the resident goes on to begin the cataract surgery portion of the case. Thank you so much for watching my video. Please email me if you have any questions.